All right, we're back. Chapter 16, Airway Management. Let's get started. So we're jumping off into endotracheal intubation. So endotracheal intubation, it involves passing an ATU tube through that glottic opening that we've already seen, that entrance to the trachea. The tube's sealed with an inflatable cuff against the tracheal wall to secure the airway and prevent aspiration. So within this, we have a couple of different types of intubation. We have orotracheal and nasotracheal. So orotracheal, inserted into the trachea through the mouth, the most common method for securing an airway in emergencies. And then nasotracheal, the tube is inserted into the trachea through the nose. So the technique is often used for patients who are breathing spontaneously, but they do require advanced airway support. Now, tracheal intubation, kind of what's been labeled as the gold standard for airway control. It's considered the most reliable way to fully control the airway in these critical situations that we're talking about. Has some advantages. Provides a secure airway, so it minimizes the risk of obstruction or displacement. It also protects against aspiration, so that's one of the biggest benefits to this over any other airway, preventing the stomach contents or other substances from entering the lungs. Now, it does have some disadvantages. It requires some special equipment like a laryngoscope, a tube, suction device, all of those things that we've talked about. And as well as by bypassing that upper airway, it eliminates the body's natural physiological functions like warming up the air, humidifying it, filtering it. So, there's a few small disadvantages. However, it is what it is. So complications, you can see bleeding, hypoxia, laryngeal swelling, laryngospasm, vocal cord damage, mucosal necrosis, barotrauma. So kind of some structures and features about endotracheal tubes. So the basic structures, they have four main components. They have a proximal end, so tube, the main body. They have a cuff and a pilot balloon, the distal tip, and then the proximal end. So it comes with an adapter that connects to any ventilation device, such as a BVM or a ventilator. Includes an inflation port. It also has a pilot balloon to manage the cuff inflation. And then the distal cuff. So that's inflated using a syringe. What that does is it creates a seal in the trachea, preventing air leaks and aspiration. So the pilot balloon, that also indicates whether the distal cuff is inflated or deflated after the tube is placed. So you're able to kind of just give it a little squeeze and understand if you've still got some air into your cuff. Centimeter markings found along the tube to measure and confirm the depth of insertion, ensuring proper placement. And then the distal end. So it features a beveled tip to make the insertion easier. It does have a side opening called the Murphy's eye, which allows ventilation even if the tip has become blocked. So even if it becomes blocked with some gunk or blood or whatever, it's still able to get some oxygen to those areas that need it the most. Now, tube sizes, variety of sizes, obviously, everything from a 2 to a 10. As you can imagine, a 2 is going to be a little bitty one, and a 10 is going to be a big old throat. Length, tube varies from 12 to 32 centimeters. There are different lengths to fit different anatomies. Have cuff tubes. So from 5 to 10 typically have a distal cuff that inflates to create an airtight seal with the tracheal wall, which is essential for effective ventilation and aspiration prevention. So one of the big things is we need to make sure that we're choosing the right size for our patient. So a tube that's too small can increase airflow resistance, making ventilation harder. And then a tube that's too large can be difficult to insert, and it can cause a lot of trauma to the airway structure. So it's important that we make sure that we choose the correct tube. That's one of the reasons it's really important maybe to have a couple of tubes with you when you sit down to get ready to intubate that patient. So in the event you look in there and you see that 7 is not the right size, you can jump up to a 7.5 or an 8 or whatever it is that's what's needed. So a stylet, that's there's a little bit of debate among whether people should use stylets or not. One way is not right, one way is not wrong. But what it does is it's a tool it used during intubation to assist in guiding the tube into the trachea. So the purpose of it's a semi-rigid wire that's inserted into the tube to help it shape it and stabilize it for easier insertion. It helps guide the tip of the ET tube over the arytenoid cartilage and through the vocal cords during intubation. So when you're preparing it, you lubricate it a little bit with a water-soluble gel, and then you bend the stylet into your curriculum talks about a gentle hockey stick curve. That's also a personal preference as well. Some people will want a bend in their tube, and some people will not want a bend in their tube. However, if you do want a little bend in your stylet just to be able to, so it will form easy with the tube. And then the stylet end should stop about at least half an inch, 1 centimeter or greater from the distal tip. Don't want any injuries coming from that. And then secure the stylet. So bend the stylet at the proximal end, so up at the top, bend it to the side to keep it from sliding further. And that stylet can do some damage if it pushes through. And then tube sizes. So pediatric tubes, 2.5 to 5 in internal diameter. It all depends upon the child's age and size. Now there is some places are kind of moving into using cuffed versus uncuffed tubes for pediatrics now. So once again, follow your local protocols. Whatever you guys are using is right. The reason that for so long we've used uncuffed tubes is because you have that funnel-shaped cricoid ring in the pediatric airway, and what happens with it is it naturally forms a seal with the ET tube, and what that does is eliminates the need for a distal cuff in most cases. Now on those tubes, you don't have a balloon cuff. They typically don't have a balloon cuff, so there's no pilot balloon to manage cuff inflation. So it's important to understand what you're using. If you're unsure of whether they're cuffed or not cuffed, you'll need to know prior to getting ready to use it. Also, the internal diameter of the nostril can approximate the diameter of the glottic opening and serve as a guide for selecting the correct ET tube size. We're not talking about if you're going to do a nasal tube, we're talking about oral. Still you can use that diameter of the nostril as a guide. There's also little tips and tricks, and you kind of within your curriculum you see little finger or thumbnail. The diameter of the patient's little finger, their little finger, or the size of their thumbnail is another quick way just to estimate the appropriate airway size. So these are all just kind of predictions, they're estimates, so keep in mind that they may or may not provide the right size tube for you. So that's what I was mentioning before. Always have some more tubes ready. Always have 3 tubes ready, one larger, one smaller, and the one that you're thinking. Laryngoscope and blades. So the purpose of the laryngoscope and blades, that laryngoscope is essential for performing orotracheal intubation using laryngoscopy. So what it does is it allows you to visualize the vocal cords and the glottic opening. Within it, there are several components within this thing, and it has a handle, interchangeable blades. The handle houses the power source for the blade's light. Now, some are disposable, some are not. It all depends on what you're using, what your service uses, but they should all have obviously a built-in light source. There's also ones that have fiber optic, all kinds of stuff out there. So the blades, straight blade versus a curved blade. So we're talking about a Miller versus a Mac. Straight blade's a Miller, designed to lift the epiglottis directly, providing a clear view of the vocal cords. So it's often used in pediatric patients or those with an anterior airway. And then a curved blade, that fits actually into the vallecula. Remember, that's that space between the base of the tongue and the epiglottis to indirectly lift the epiglottis. And that's commonly used in adult patients. There's a lot of people, it's just what you get comfortable with. So you need to be able to use both in the event something happens and you only have one style of blade. But typically most people get kind of just start kind of using one blade as they get better at doing this skill. So how's the whole thing work? So the tip of the straight blade designed to go under the epiglottis, mention that, and directly lift it to expose the vocal cords. Now this blade's particularly helpful in infants and small children because they often have like this really kind of long and floppy epiglottis that can obscure the airway. Now be careful with adults because it's very easy to damage teeth if you're using a straight blade and not being thoughtful about the way that you're doing it. And then a curved blade. So it has some safety advantages. It's less likely to be levered against the teeth, making a safer choice for less experienced paramedics. That's why a lot of times some newer paramedics may or may not use, a Mac versus a Miller, because typically people are kind of pushed towards probably a Mac as they're newer. But the curve of the blade aligns naturally with the shape of the tongue and the pharynx. And what that does, it allows for smoother navigation during intubation. So the blade's tip rests in the vallecula. Remember, we just mentioned that. You should hopefully remember that from A and P, but that's that space between the tongue and the epiglottis. And then from this position, it indirectly lifts the epiglottis, gives you a really nice and hopefully a clear view of the vocal cords. But as I said, make sure that you have both blades, because you may need both. Now they come in different sizes, these blades, 0 to 4. Infants are 0, 1, and 2 for infants and pediatrics. And then adults are 3 and 4. Pediatric blade selection. So for children, the blade is often chosen based on their age and their height, or their height, providing a more, kind of tailored fit to them. Adults, choice depends on the clinician's experience and then the size of the patient. So if you have, a really large patient, you may need a 4 versus a 3. So just make sure that you're familiar with being able to choose the right blade and what will be needed. So oral tracheal intubation, let's talk about with direct laryngoscopy. So it involves passing that tube through that glottic opening like we've mentioned. So when do we do this? When airway control is necessary. And there's several reasons for coma, respiratory arrest, cardiac arrest. And what we're doing was providing ventilatory support in cases of impending respiratory failure, for prolonged ventilatory support in critically ill or injured patients in cases of traumatic brain injury, trying to protect that airway and maintain oxygenation. And then, of course, unresponsive patients who can't protect their own airway. So when an impending airway compromise is expected, and we're talking about burns or trauma or stuff like that, things that might obstruct the airway, that's going to be a good time too. Some precautions. Make sure you protect yourself. You got blood and saliva and all kinds of other body fluids, increasing the risk of infection or contamination. So in the event, you want to use an N95 mask or safety glasses, or a full face shield is not a bad idea. You always need to have gloves. Heck, you might even want a gown if, in the event they got a lot of stuff going on. Okay, Chapter 16, Part 4, Airway Management. Let's get this thing knocked out. We're on our final portion. So, pharmacologic adjuncts to airway management and ventilation. So we're going to talk about, as you can see, lots of pharmacology. So, why do we use medications for intubation? Well, when it comes to managing airways, the meds can make a really big difference, and here's why there's a go-to. So it makes intubation more comfortable. Nobody likes having a tube shoved down their throat, so meds help reduce that discomfort for the patient. It also helps lower the risk of complications. So by keeping the patient calm and relaxed, meds make it less likely that something goes wrong, like airway trauma or even gagging. And then it also helps when the patient can't cooperate. So if a patient's too sick, they're combative or scared to stay still, these meds let you take control and get the job done. So in these situations, using that right medication makes intubation smoother, safer, less stressful for you, as well as the patient, makes it better for everybody. So sedation in emergency intubation. So when you're prepping to intubate, sedation isn't just about making things easier, it's about ensuring that the patient's safety and comfort. So why sedation is important? Well, it helps by calming the patient's anxiety. It helps to cause some amnesia so they don't remember the procedure. And one of the big pieces, it reduces that gag reflex. So that helps make the process much smoother. Now there is kind of this little, almost like a little Goldilocks problem. So is it too much or too little? So under sedation, not enough sedation. So when the patient isn't sedated enough, you might run into a few problems. Some of them might be inadequate cooperation. So it makes, the thing with that is it makes the procedure harder, also riskier. gagging, which can lead to complications like aspiration or even airway trauma, and then incomplete amnesia. That leaves the patient with a traumatic memory of the event. So it's important that we get this sedation correct. Too little, the patient fights the procedure. Too much might compromise their safety, which we're going to talk about. So over sedation. So too much sedation is what we're saying. So while sedation, it helps with intubation, going overboard can create some serious problems. And there are several of them that we have listed. So you see uncontrolled general anesthesia. So the patient becomes fully unconscious, and that makes it harder to manage their airway effectively. They also can lose their protective airway reflexes, so reflexes like coughing or swallowing are suppressed, increasing the risk of aspiration or obstruction. Respiratory depression, breathing slows or stops entirely, requiring immediate intervention. And then, of course, just complete airway collapse. So, the patient's airway may completely close off, leading to critical complications. And then hypotension. So sedation can lower blood pressure, which may further compromise a critically ill patient. So we want to make sure that we're paying attention, as we talked about, under as well as over sedation. Over sedation can quickly turn a manageable situation into quite an emergency, just within seconds. Now, when we talk about the level of sedation, we really want to in my opinion, we kind of want to start with the goal in mind. So the amount of meds that you give depends on how deeply you need to sedate the patient. However, remember, when we talk about all of these things, and maybe we talk about dosages and protocols and all of that stuff, you always refer to your local protocols. So two types of meds that we commonly use for sedation. We use analgesics, then we use sedatives as well. Analgesics, these help kind of by reducing the perception of pain. So think of them as painkillers that make the procedure more tolerable for the patient. And then sedatives or hypnotics, they're used to calm the patient, decrease anxiety, even induce some sleep. So the thing to remember though with these sedatives, they do not take pain away. They don't reduce pain. So they're often paired with an analgesic for procedures like intubation, and like what we're talking about. So benzos, what are they? They're sedative hypnotic drugs. They're used to calm patients, relax the muscles, manage the airway, or seizures. Some common ones that we see is diazepam or midazolam, so Valium, Versed, are widely used for their sedative effects. What do? Well, that's a good question. They provide muscular relaxation as well as some mild sedation. They're used as an anxiolytic as well, so an anti-anxiety, and then anti-seizure meds. They do cause some anterograde amnesia, so that means the patient won't remember what happens after the drug is administered. Let's focus on midazolam for a second. So it's much more potent, about 2 to 4 times stronger than diazepam. It also works faster. It's faster acting. It works quickly, making it ideal for emergencies. Has a shorter duration, so its effects don't last as long, which can be beneficial for shorter procedures. It's not an induction agent, so large doses are needed to induce full sedation, making it less practical for intubation induction. And then there is an increased risk with large doses, so using a large amount of these really increases the chances of complications like respiratory depression or even hypotension. So making sure that you're doing your doses properly as well as monitoring is going to be really important with these patients when we're using these meds. Neuromuscular blockers, so they're often a better choice for achieving muscle relaxation because they require smaller doses compared to benzos. Now there are side effects when we talk about benzos. Breathing can slow or stop, so respiratory depression requiring immediate support. They can give a little bit of slight hypotension, so blood pressure may drop, which can be problematic in unstable patients. When we start talking about hemodynamically unstable, then that can be a problem. And then we do have some antagonists here. So we've got flumazenil or romazicon. If complications arise from benzo use, flumazenil is the antagonist that can reverse their effects. So it's kind of like kind of hitting the undo button for benzos. But it needs to be used with caution in patients with a seizure history or a long-term benzo use history also. And then dissociative anesthetics. So dissociative anesthetics, they're unique in how they work. They both sedate as well as provide pain relief while altering a patient's perception of their surroundings. So the way these things work is they almost create this sense of detachment from the environment as well as their self. So it kind of just distorts the sight and sound perception. So they may feel disconnected from reality, which obviously would help achieve effective anesthesia. Some of the effects, you get a hallucinogenic effect, so it alters the sensory perception. Amnesic, so patients won't remember the procedure. Analgesic, provides effective pain relief. And then a sedative as well, so it calms a patient and facilitates procedures like intubation as well. So talking about ketamine, some of the nice things about ketamine is it works quickly, has a short duration of action, and which makes it ideal for emergency use. And some of the doses, you have a low dose, 0.2 to 0.3 milligrams per kilogram. That's used for pain relief, so analgesia without full dissociation. And then when we get into high doses, we're talking about 2 milligrams per kilogram. That induces sedation. That's often given before a neuromuscular blocker to facilitate intubation. Now, you do get some sympathomimetic effects. So remember, sympathomimetic mimics a sympathetic nervous system. It stimulates the sympathetic nervous system, making it an excellent choice for patients with hypotension or an unstable blood pressure. It's considered a hemodynamically stable sedative. So unlike other agents that can lower blood pressure, ketamine is a really good choice whenever you have maybe a hemodynamically unstable patient. There is a reemergence phenomenon. That's when the patient wakes up, they might experience vivid dreams or hallucinations. That's kind of a reemergence phenomenon. So, it can be unsettling. So preparation, reassurance, all of those things are important. So ketamine's, a really powerful, very versatile drug for emergency airway management, especially in those cases where we have a hemodynamically unstable person. So we do need to understand its effects as well as challenges, potential challenges, I guess, ensures effective and safe use by understanding those and keeping those in mind. And then opioids, potent drugs that play a big role in managing pain and sedation during these emergency procedures. However, they do come with significant risks if we don't use them carefully. So what they do, they act as a CNS depressant, creating a state of insensibility or even a stupor, making them effective for pain relief and sedation. Now, what might we use them? It's commonly used as a pre-medication to calm the patient, or maybe an induction agent to help prepare the intubate for intubation or sedation, and then in maintenance to sustain sedation or amnesia as well. We have a couple listed, fentanyl and alfentanyl. So fentanyl, one thing to keep in mind, 70 to 150 times stronger than morphine. A really nice thing is its onset is that it works fast. It also wears off quickly, so that makes it ideal for short-term procedures. And then alfentanyl, less powerful than fentanyl, works even faster though, shorter action, it's also cleared from the body quicker, making it a really good choice for brief interventions. Now, all of these things that we talk about obviously have risks and side effects, so they can cause some profound respiratory depression. So, you need to have some close monitoring of breathing. It can also lead to severe hypotension and bradycardia, especially in unstable patients. CNS depression can compromise a patient's ability to maintain their own airway. So we mentioned a reversal agent before, so within this one we're going to talk about Narcan or naloxone. So if complications arise, Narcan would be the antidote to quickly reverse these opioid effects. However, be cautious that reversal can lead to acute withdrawal and symptoms or pain returning abruptly. So non-opioids or non-barbiturates, so we'll talk about etomidate. That's really a big go-to drug in emergency settings. Etomidate is a hypnotic sedative. That's used to quickly induce general anesthesia while maintaining hemodynamic stability. So why do we use it? It's fast acting, it works quick, making it ideal for an RSI. Short duration, it wears off quickly. That's which is useful for procedures requiring temporary sedation. One nice thing about it is, unlike other sedatives, etomidate has minimal effect on the pulse rate and the blood pressure. So it's great with cardiovascular instability. So we're talking about hemodynamic stability here. Has a little effect on ICP as well, or intracranial pressure, making it safe for patients with traumatic brain injuries or other conditions that might be affecting the brain. So it's important, etamidate's a reliable choice for induction in critically ill patients, especially those at risk of hemodynamic compromise, and it kind of offers this balance of effectiveness and safety as well. So advantage over other agents. So accommodate does not cause that histamine release or even a bronchoconstriction, but makes it safer for patients prone to allergic reactions or airway issues. Now it does come with a downside, myoclonic movements. That's has a high incidence of myoclonic muscle movements, involuntary muscle jerks, which can be uncomfortable. Generally they're not harmful though. Now etomidate is ideal for certain patients, and what we're talking about is useful for induction in patients with coronary artery disease, because we talked about it avoids significant hemodynamic changes, protecting the patient as well, but protecting the heart. ICP issues, so it maintains cerebral perfusion pressure, and then borderline hypotension or hypovolemia, because it has those minimal effects on blood pressure, which makes it a safer option for patients with compromised circulation. So once again, it as well is pretty versatile and effective induction agent, especially for those critically ill patients with things that we just talked about, those issues. Now, the big stuff, those neuromuscular blockades, and talking about emergency intubations. So, this is the challenge of combative patients. This is that can really help us with these patients. So, patients that are experiencing cerebral hypoxia often become combative. So aggressive, belligerent, those type of things, they uncooperative, making airway management significantly harder. So the first thing we want to make sure that we do is treat the cause first. We don't want to just start slamming in meds. Let's see if we can treat the cause first. So we want to address that underlying hypoxia with some aggressive oxygenation and ventilation to improve their condition. And then, something to think about, because physical restraints was the thing, is a little outdated now. In the past, physical restraints were commonly used to manage uncooperative patients, but this posed a risk of injury and as well as escalation. So really, chemical paralysis, a little bit of a safer option as well, depending upon your protocols. So today, neuromuscular blocking agents, they allow for almost like kind of a quote chemical paralysis, which is safer and more effective, and it temporarily paralyzes the patient to facilitate intubation and other airway management procedures. So, one thing to say really, the kind of the advent of getting neuromuscular blockers into the ambulance, that's really for a game changer for us in emergency airway management, because it enables that safe and efficient intubation while avoiding those risks associated with physical restraint as well. So why use paralytics? While sedatives alone can help with intubation, those neuromuscular blocking agents are far more effective for achieving complete paralysis, because they affect all those skeletal muscles, quickly eliminating movement and resistance. So within 1 to 2 minutes, that patient becomes completely paralyzed, which leads us to a couple of things. Breathing is stopped, so that requires immediate ventilation support. Jaw muscles go slack, making intubation easier, and then the tongue can obstruct the airway, emphasizing the need to act quickly and secure the airway. So absolute confidence in airway management is going to be crucial here. You need to be 100% confident you can secure the airway before using paralytics, because these agents do not affect cardiac or smooth muscles, so circulation remains stable, but the breathing stops. Paralytics do not affect awareness. Paralytic agents have no effect on their LOC or their level of consciousness. Patients still fully able to hear, feel, and think, even though they can't move or communicate. So always combine with sedation and analgesia. Never administer a paralytic without first treating the patient's pain and providing sedation to ensure comfort and reduce psychological trauma. So these obviously are incredibly effective, but they do come with some significant risk. So that, as we've talked in the past, and we'll go on more, that proper preparation is going to be a really big key here. So how it works, how does the pharmacology of neuromuscular blocking agents work? Skeletal muscles are voluntary, meaning they rely on signals from the somatic nervous system to contract. So acetylcholine has a role in this, and when a nerve impulse reaches the end of the motor nerve, it triggers the release of acetylcholine into the synaptic cleft, so that space between the nerve and the muscle, activating the muscle contraction. So acetylcholine diffuses across the synaptic cleft and then binds to the receptor site on the muscle fiber. Now that binding triggers a process called depolarization, where the muscle fiber's electrical charge changes. That's where contraction begins. So once enough motor end plates are depolarized, then the muscle fiber contracts. That depolarization is really brief. That process lasts only a few milliseconds because of that enzyme acetylcholine esterase, which quickly breaks down acetylcholine, allowing the muscle to reset for the next signal. So where they work, they act directly at the neuromuscular junction, that connection between the motor nerve and the muscle fiber. These meds relax muscle by interfering with that action of acetylcholine, preventing the muscle from contracting. So within this, we have two categories of paralytics. So we have depolarizing and non-depolarizing. So depolarizing mimics acetylcholine and binds to the receptors, causing a brief contraction or depolarization before preventing further signals. And then non-depolarizing block acetylcholine from binding to its receptors, completely preventing depolarization and muscle contraction. So it's going to be, not necessarily important, but it is just understanding the two types of paralytical agents helps guide their use in different clinical scenarios. So those depolarizing agents are fast-acting, but they are short-lived, while non-depolarizing agents provide longer, more controlled paralysis. So how does the depolarizing neuromuscular blocking agents, how does it work? Depolarizing binds to the acetylcholine receptor sites, mimicking acetylcholine, but unlike acetylcholine, they are not quickly broken down by acetylcholine esterase, so they keep the muscle in a prolonged depolarized state, preventing further contraction. So now let's talk about succinylcholine. Succinylcholine chloride, only depolarizing neuromuscular blocking agent used in clinical practices. So you do get some fasciculations, which are brief, kind of just that uncoordinated twitching of small muscle groups. Now these twitches happen as the drug initially depolarizes the muscle before paralysis sets in. Common side effect of these is just some generalized muscle pain after the drug wears off. It's likely caused by the fasciculations and muscle activity during the onset of paralysis. But it does have a rapid onset, short duration, works incredibly fast. Onset 60 to 90 seconds, durations 5 to 10 minutes. Rapid action makes a great choice for its use as an initial paralytic during rapid sequence intubation or RSI. Now, use with caution though in certain patients when we're talking about succinylcholine, or just sucks. If you hear me say sucks, you probably are aware of that, but that's what we're talking about. So burns or crush injuries, blunt trauma, all these patients, they need some extra caution because succinylcholine can cause hyperkalemia, so high potassium levels, which can lead to life-threatening cardiac arrhythmias. Also the risk of bradycardia in pediatric patients, so it can slow the heart rate, particularly in children. So to prevent this, once again, if your protocols call for it, then you administer some atropine before giving sucks in those pediatric patients. So once again, we're kind of just taking them up before we bring them down and just to kind of avert the crisis. And then non-depolarizing. So these agents also bind the acetylcholine receptors, but do not cause depolarization of the muscle fibers. Instead, they block acetylcholine from binding, preventing muscle contraction altogether. Now, in sufficient doses, these meds outnumber the acetylcholine molecules in the synaptic cleft, ensuring complete paralysis. So it's competing with acetylcholine. Also prevents you can prevent the fasciculation. So when given in small doses, before a depolarizing paralytic like sucks, they can prevent fasciculations or those muscle twitches. And there's several of them that we talk about, as well as your curriculum does. VEC, which has an onset of about 2 minutes, a duration of around 45. Rocuronium, around a 2 minute or greater than 2 minutes onset, durations 30 to 60 minutes. And then pancuronium or Pavulon, onset 3 to 5 minutes, durations about 60 minutes. So all three of these last longer than sucks, making them suitable for maintaining paralysis after intubation. So kind of ideal for the extended paralysis, because these agents are perfect when the patient needs to remain paralyzed for longer periods, such as during a prolonged procedure or even a critical care transport. So only administer these guys after the airway is secured. These meds do not affect consciousness or pain, so you must ensure their airway is secured, and then sedation and pain management's in place before administering. So remember, we're saying those non-depolarizing agents, they're really good tools for long-term paralysis. So RSI, what is it? It's a method for safe, smooth, and rapid induction of both sedation and paralysis, followed immediately by intubation. So when might RSI be used? It's primarily used for responsive or combative patients who need to be intubated but are unable or willing to cooperate due to some respiratory distress or even respiratory failure, or a medical or traumatic condition that might require airway control. So what that does is it really helps us to quickly and effectively take control of the airway in some of these challenging situations. One of the big things, it minimizes risks of aspiration, prevents agitation or complications during intubation. That's why they're such great tools. So preparation. We talked about preparation a little bit. So explain and reassure. Let them know what's about to happen. So in simple terms, if they're responsive, obviously, reassure them the process is necessary to help them breathe and that you'll ensure their safety. And then you do want to monitor your patient. So make sure you have a cardiac monitor on them. We want to make sure that we're tracking the heart activity, a pulse ox to monitor O2 levels throughout the procedure, and then prepare your equipment. So double check, assemble everything that you need. Your tubes or laryngoscope, your bougie, everything you need, and then make sure that you have suction. Suction is going to be pretty important to get be able to clear those secretions, or maybe even if some vomitus happens during that procedure. Then pre-oxygenation. So why is it essential? So always pre-oxygenate your patients before starting RSI to maximize their oxygen reserves and prevent hypoxia during the procedure. So we've talked about that. We've talked about denitrogenation. We've talked about hyperoxygenation, all of these things. So how do you pre-oxygenate? So if the patient's breathing spontaneously with a good tidal volume, high flow O2 with a non-rebreather is going to be good. For hypoventilating patients, if that patient isn't breathing effectively, may need to provide some assisted ventilations and using a BVM with a high flow O2 to make sure we are getting adequate oxygenation. Now, once a paralytic agent is administered, avoid bag mask ventilations if possible. We really want to try to minimize that risk of gastric insufflation or aspiration. So pre-oxygenation is going to be really critical to reduce that risk of hypoxia, during the apneic period. So once we start slamming these meds, that's where we're talking about an apneic period of intubation. So they quit breathing. So we need to make sure that we've gotten more O2 out and more nitrogen out, or more O2 in and more nitrogen out. And then pre-medication. So in the event that you are called for with a defasciculating dose, you can use that. It's just giving a small dose of the non-depolarizing paralytic. That's, of course, if time allows, and as well as your protocols, to minimize fasciculation. So typically we're talking about 10% of a normal dose of a non-depolarizing agent. That'll kind of offset those fasciculations. And then you may want to use some atropine to reduce the risk of bradycardia, which is a common side effect of succinylcholine, especially as we mentioned in pediatric patients. And then sedation and paralysis. So want to administer that sedative first. If the patient's hemodynamically stable, give a sedative to ensure comfort, amnesia. If the patient's unstable, want to more opt for sedatives like ketamine or etomidate. Remember, ketamine helps to maintain the blood pressure because it has some of those sympathomimetic effects. And then etomidate causes minimal impact on blood pressure. Then we'll follow it up with our paralytic. So once the patient is adequately sedated, we'll administer the paralytic agent to facilitate intubation. And then the time to full paralysis, it should be completed within 2 minutes, allowing for rapid airway control. Now, we should be able to recognize adequate paralysis, so signs that paralysis, that we've been able to achieve that, apnea, the patient's no longer breathing spontaneously. Then you have laxity of the mandible, so the jaw muscles are completely relaxed. And then intubation, so same procedure, just a different setting. The technique for intubation during RSI is the same as in any other situation. Key difference is that we did rapid sequence intubation. That's the rapid sequence at sedation, paralysis. Now we're moving to intubation. So what to do if the intubation fails initially? If you can't complete the intubation quickly, if the patient's or the patient's oxygen saturation drops, stop immediately, get back on to bagging them with 100% O2. Once their O2 sat has returned to an acceptable level, you can attempt intubation again. And then proper ventilation technique if it's needed. So when ventilating with a bag mask device, deliver breath slowly with 1 second per breath. And remember, just to give just enough so you have some visible chest rise and fall. We don't want to overinflate, as well as push air down into the belly. So once we've achieved intubation, once we've got them intubated, let's talk about some of the steps after the tube's placed. So once that ET tube is in the trachea, we want to talk about a couple of steps after that. So you'll inflate the cuff, use a syringe to inflate the cuff on the ET tube to create that airtight seal. We don't want to have air leaks or aspiration. Want to remove our stylet. Carefully remove the stylet while holding the tube steady to avoid dislodging it. Remember, we talked about not ever letting go of that thing until it's nice and secure. And then you want to verify your tube placement. So auscultation, listening for breath sounds in both lungs, absence over the belly. And then, of course, capnography to verify exhaled CO2. We'd want to see some chest rise during ventilations, obviously. And then secure the tube. So hopefully you are able to put a nice tube tamer on them that stabilizes the tube. And then what the main thing with that does, prevents accidental displacement. And then resume your ventilations. So ventilate the patient at an appropriate rate based on their condition. So apneic adult with a pulse, 10 breaths a minute, 1 every 6 seconds. Apneic pediatric, 20 to 30, 1 every 2 to 3 seconds. And then a patient in cardiac arrest, 10 breaths a minute, asynchronous with compressions. So, properly managing that tube after placement ensures effective ventilation. It also reduces the risk of complications and gets that critical oxygenation for the patient. Now, maintenance, we talked about some long-term stuff. So the maintenance of paralysis and sedation. So confirm your successful intubation. We just kind of went over that. So once you're absolutely certain it's properly placed, you can administer additional paralytics if needed. So you can transition into that non-depolarizing agent, the one that will last much longer. So if you start with SUX, remember it's a short-acting paralytic, switch to a non-depolarizing to maintain that long-term paralysis for continued airway control. Long-acting paralytics. So if you used a long-acting paralytic initially, like VEC or ROC, additional dosing is typically not needed. One thing we need to make sure we're doing is paying attention to A would be to monitor the sedation and then the blood pressure as well. So you'll want to consider administering sedation as necessary to keep them comfortable and unaware, and then continuously monitor their blood pressure to ensure stability, as both paralytics and sedatives can cause hypotension. We've talked about that. And then it's not a bad idea kind of just to have a checklist with all of this, of all of your steps as you become more and more comfortable with this procedure, but to have a checklist and go through it so you know you're taking care of everything properly. So alternative advanced airway devices. So supraglottic airways. We're going to talk about King's, latex-free, single-use device, single lumen. It's blindly inserted into the esophagus, making it easy to place without the need for direct visualization. So it can be used in a couple of different scenarios. Apneic patient, one of the things it does, provides positive pressure ventilation when spontaneous breathing is stopped. And then spontaneously breathing patients. So helps maintain a patent airway in patients needing advanced airway management. They're very versatile, available in adult, pediatric sizes. So these things are available for a wide range of patients. It features a curb tube with a ventilation port situated between the two inflatable cuffs. So you have a distal cuff, seals off the esophagus, which prevents air from entering the stomach. And then you have a proximal cuff, which seals the oropharynx, ensuring proper ventilation through the airway. Ventilation through the device, though, with the openings located between the two cuffs, allow air to flow directly into the lungs, providing effective ventilation. So you have a couple different kinds of King airways. So you have LTD, suitable for use in adults and children. LTSD, additional port for gastric suction, and lots of sizes, comes in 7 sizes. It's a height and weight measurement type thing. So color coded, make sure we're getting the right patient for the right device. Shared features. So both types include a proximal and pharyngeal cuff to seal the oropharynx. They both have distal cuffs to seal the esophagus, several ventilation outlets located between the cuffs to ensure effective airflow, and then the ET tube introducer compatibility. So both devices allow the use of an ET tube introducer, so like a gum bougie or something like that, for transitioning to a more advanced airway if necessary. The big differences is the LTD, the distal end is closed, so it limits its function to airway management. The LTSD, the distal end is open, which permits the insertion of suction catheter and makes the LTSD more versatile for managing patients with significant gastric distension. Now, indications, who is it for? Excellent alternative for failed intubation attempts. So it offers a secure airway when endotracheal intubation is not successful. And then situations where bag mask ventilation alone, they're insufficient or difficult. They are similar to other esophageal devices, shares the same benefits, risks, and considerations as other airway devices inserted into the esophagus, like simplicity of placement, but potential for complications. So contraindications, the King LT does not eliminate the risk of vomiting or aspiration. Remember, we talked about that ET tube is going to be your gold standard in what's best for the airway in the event we're able to get it. However, at this point, we're kind of talking about maybe a failed airway. So now, high airway pressures may cause air leakage into the stomach, so that may increase distension, air escape from the mouth, reducing ventilation efficiency. And then there's the when not to use, kind of more contraindications as well. Intact gag reflex, esophageal disease. So if they have esophageal varices or structures or something that might inhibit that, we don't want to use it. As well as a history of ingesting a caustic substance. That can definitely, the insertion could worsen those injuries. Now, confirming the proper placement, we want to make sure that it's correctly placed. We observe for chest rise during ventilation. We also auscultate lung sounds bilaterally, check for absence of sounds over the epigastrum. And then use waveform capnography, going to be the most reliable method to confirm exhaled CO2. Some complications, laryngeal spasm, vomiting, hypoventilation, those are all things that can happen secondary to these things. There can be some trauma from the improper technique. So the surrounding tissues, the airway, both of those can get some trauma if we're not doing it properly. And then there is some ventilation difficulty from the balloon placement. So the pharyngeal balloon can sometimes push the epiglottis over the glottic opening, obstructing airflow. If that happens, just gently withdraw it slightly until the ventilation improves. So the insertion technique, this is just one that I'd put in, I just kind of put in here. So you'll see on 1613 is inserting a King airway, but make sure the patient's height and weight are the key factors in selecting the correct size. Refer to the device size chart to ensure proper fit for optimal performance. And then actually it's right here. Select the correct size. Prepare the airway, so test your cuffs, get everything prepared. Apply a small amount of water-based lubricant to the distal end of the tube, avoiding the ventilation ports. Make sure you position your patient. We want them in the sniffing position, so the head slightly extended, neck flexed as well. Not a good idea if they have a cervical spine injury, so maintain the head in a neutral position if that's the case. You want to insert your airway, so hold the airway with your dominant hand with the curved tip facing the chin. Open the patient's mouth and insert the tip into the right corner of the mouth. Advance the device along the natural curve of the airway, rotating it to the midline, and then stop when the base of the connector aligns with the patient's teeth or gums. Go ahead and inflate your cuffs. So use that syringe. You want to make sure you use the recommended amount of air based on the size. Ventilate your patients, confirm your placement, secure your airway like we talked about. And then an LMA. So great option for patients who need more airway and ventilatory support than what a BVM can provide. No need for visualization. So unlike other devices, the LMA can be inserted blindly, meaning you don't need direct visualization of the airway to place it properly. It works kind of as a conduit, so connecting the glottic opening to the ventilation device, allowing for effective delivery of oxygen and ventilation to the lungs. So design and placement. LMA has an inflatable silicone cuff, surrounds the opening of the larynx. Cuff is positioned in the hypopharynx, just above the vocal cords. Make sure you're using some proper positioning. So opening of the LMA aligns with the glottic opening. The tip of the device is positioned in the proximal esophagus, helping prevent air from entering the stomach. And then you have that inflatable cuff. It inflates to conform to the airway's natural contours. And so what that does, relatively airtight seal and ensures effective ventilation without significant air leaks. Once again, it doesn't secure the airway though. So we've got some indications and contraindications. So it's a reliable alternative, like we mentioned, to bag mask ventilation particularly in cases where intubation is not possible or has failed. So not great patients for these. Obese patients, so the LMA is less effective in patients with obesity due to the altered airway anatomy and increased airway resistance. There's a risk of regurgitation, so that's not going to be a great patient either. So if they have a hiatal hernia or higher risk of regurgitation, and what that does is increases the chance of aspiration. High pulmonary pressure, so how you might think about that, it's ineffective for these that require high pulmonary pressure for ventilation, so it's not going to be easy to maintain a proper seal under those conditions if they have high pulmonary pressures as well. And with everything, you have advantages and disadvantages of them, and we're going to talk about the LMAs. So it provides better ventilation than a bag mask device, combined with the oral or nasal airway. So not better than a tube, probably not better than a king. It's hand-freeze operation. So once placed, it doesn't require constant maintenance of a mask seal. No need for laryngoscopy. It can be inserted blindly. It has a reduced risk of trauma, and then protection from secretions. So it does provide some protection against upper airway secretions, which help reduce contamination of the airway. Disadvantages, aspiration risk, that's the main thing. The main disadvantage of LMA is that it does not protect against aspiration. And that's going to be a critical consideration in patients at the risk of regurgitation. So, for someone that could end up kind of losing everything, this is probably not a great choice. Also, air insufflation, not a great advantage, a big disadvantage. So prolonged ventilation using an LMA, some air may enter the stomach, increasing the risk of gastric distension and then subsequent regurgitation. So not a primary airway in emergencies, not considered a primary airway in emergency situations, particularly when there's a high risk of aspiration as well as high pulmonary pressures. But it's something that's out there, so we'll talk about it. Some complications. Most significant complication we mentioned before, regurgitation and aspiration. So, this is used in surgery a lot. However, while you guys are out doing OR clinicals, you're more than likely going to see them. And that's why these are good in fasting patients. So that really minimizes the risk of aspiration. should only ideally be used in fasting patients or those with a confirmed empty stomach. Size options, so come in different sizes, match the patient's weight to the proper fit. Structure device consists of a tube for airflow and then an inflatable mask cuff. LMA includes a one-way valve assembly, allowing it to be inflated with a predetermined volume of air, ensuring a proper seal without overinflation. Hang on a second. So we do see a couple of different LMAs out there. You have an LMA Pro Seal, which has a built-in drain tube that allows the stuff to come out, so to redirect those expelled gastric contents, reducing the risk of aspiration. And then the Supreme, an anatomically shaped device that includes a gastric access port, making it ideal for patients at higher risk of regurgitation or aspiration. And you can pass a 6.0 tube through these, through a size 3 or 4 LMA, and it kind of gives you a little pathway to transition into endotracheal intubation when needed. So some easy steps for inserting them. Make sure you choose the right one based on the patient's weight. Inflate the cuff to check for leaks. Make sure you got them properly positioned in the sniffing position, positioned in the sniffing position. Lubricate and hold the LMA, so only a small amount of water-based lubricant at the back of the LMA cuff. Hold it like a pin with the cuff facing forward and your index finger at the junction between the tube and the cuff. And then go ahead and insert the LMA. So open the patient's mouth, insert the LMA into the hard palate, push it down along the palate's curve following the natural contour of the airway, and then advance until you feel some resistance. Usually going to be, when properly seated in hypopharynx, is when you start to feel that resistance. Inflate the cuff, confirm placement, and then capnography, all the good stuff. Bilateral lung sounds, listen to the belly, all those things. And then eye gels. So similar to the LMA, following the natural curvature of the airway for quick and straightforward placement. So the eye gel forms a non-inflatable anatomical seal around the pharyngeal structures, laryngeal structures, paralaryngeal structures, covers everything. So it eliminates the need for cuff inflation, reducing the risk of compression trauma that can occur with devices requiring an inflatable cuff. So eye gel as an alternative to intubation. Eye gel is commonly used as a supraglottic airway device, serves as a practical alternative to endotracheal intubations, especially in emergencies or situations where intubation isn't feasible. So you have a couple features of the eye gel: an integral bite block, so it has a built-in bite block, gastric access channel, includes a channel to accommodate a 10 French gastric tube, so you can get in there and decompress the stomach, try to get some of the stuff out, which reduces regurg and aspiration. Supplemental oxygen port, get a support strap. Color-coded proximal hook ring, so each eye gel has a color-coded hook ring at the proximal end to indicate the device size. It also serves as an anchor now for attaching the support strap to secure the device in place. And then the size and the weight for the eye gel are printed directly on the device, making it easy to choose the correct size for the patient. And some of those steps, so you prepare the device, check for damage, ensure it's ready to use, a little bit of water-based lubricant as we mentioned, position in the sniffing position, hold it correctly, hold it like a pin with your dominant hand, ensure the opening is facing forward, insert the eye gel, insert it into the mouth following the curvature of the hard palate, confirm placement, secure the device. Cricothyrotomy. Remember, when we're talking about these skills just with these lecture videos, I'm just quickly going over these things. These are skills that we're going to be doing over and over in the lab. So this is, if nothing else, more than just kind of give you a little heads up about what you may or may not be doing. So methods for securing a patent airway when the conventional techniques fail. We're going to talk about some cricothyrotomies, being surgical as well as needle. So a direct surgical approach to establish an airway, and then a needle, less invasive technique using a needle to secure temporary ventilation. So there is some important anatomy to make sure that we're paying attention to. So we kind of have mentioned about landmarks and different things. There's going to be some key landmarks here. So make sure you're familiar with the structures of the anterior neck, particularly the cricothyroid membrane. So there's lots of important blood vessels here when we're talking about them. You have the superior cricothyroid vessels, but it runs transversely across the upper third of the cricothyroid membrane. And then you have the carotid arteries, so they run vertically and located lateral to the cricothyroid membrane. So in the event that, in the event you do this, you're going to have to manage some bleeding. Minor bleeding, typically from sub-Q and small skin vessels, is expected when incising the cricothyroid membrane. Typically, it's usually easily controlled with light pressure after the tube's inserted. That's not always the case, though. Sometimes it can be a little more than minimal. But what it involves, so we're talking about using a scalpel to cut into that cricothyroid membrane. You're going to insert a tube directly into the subglottic area of the trachea to establish your airway. So why the cricothyroid membrane is ideal? So one of the things is it has a lack of critical structure. So no major blood vessels or other critical structures are between the skin and the airway, reducing the risk of severe complications. And then the proximity to the skin as well. The airway is close to the surface at this level, making access quicker and easier in emergencies. And there's a tough posterior wall. So the cricoid cartilage forms a strong protective wall at the back of the airway. That structure can really help prevent accidental perforation into the esophagus, which just lies right behind the trachea. So types, you got surgical crics. Traditional method involves incising the skin and the cricothyroid membrane with a scalpel, inserting a tube directly into the trachea to secure the airway. And then there's a modified cric variation of the surgical technique that may use specialized tools or slightly different steps to achieve the same result. Then there's some kits out there, as you see on your screen, some prepackaged kits. They're designed for, that's something you can use quickly. You have quick trach kits, quick trach 2 kit. So, obviously you need to be familiar with if you're, maybe you have a quick trach kit and maybe it's not in the truck. So you're going to need to make sure you're familiar with the surgical cric and not have trouble landmarking it as well as doing the procedure. So indications. It's performed when conventional methods of securing a patent airway have failed. So some of these common scenarios, and we're talking about this, is severe foreign body obstruction. So when that obstruction cannot be removed using the McGill's or direct laryngoscopy, airway obstruction from swelling, severe anaphylaxis, burn injuries, which can cause a lot of upper airway edema, like that young fellow there, massive maxillofacial trauma. So maybe some extensive injuries that make conventional airway management impossible. Fractures, tissue displacement, all those things, or even the ability or inability to open the mouth. So depending on what's causing that. So some special considerations for patients with head injuries and trauma. In the event they have trismus or lockjaw, they may require cricothyrotomy when the nasal tracheal intubation and nasal airway placement are contraindicated or impossible. Now, the main contraindication is the ability to secure airway through less invasive means, meaning you can endotracheal intubate them or use a supraglottic. So if you're able to do that, that's going to be your first step. Some other contraindications, if you're unable to identify anatomic landmarks, so when you cannot confidently locate that membrane, that cricothyroid membrane, the procedure should not be attempted. Crushing injuries to the larynx or the trachea, underlying anatomic abnormalities, age younger than 8 is an important one. When we start talking about age younger than 8, that larynx of those young children, too small and delicate to accommodate a tube, large enough to ventilate effectively without causing damage. So in the event you have a person that you're unable to to get an advanced airway in as well as do a crike, then we're going to be just moving fast. So rapidly transport to whoever's able to manage that properly. Some advantages and disadvantages of this surgical crike. So one nice thing is it can be performed rapidly. So, this is something kind of almost a life, I guess it's not almost, but it's a life-saving option in some very critical emergencies that you can do quite quickly. No C-spine manipulation, doesn't require movement of the C-spine, making it safe for patients with suspected spinal injuries. It has a larger tidal volume, especially when we talking about a needle crike, much larger tidal volume for them. Now it does have some disadvantages, not really great procedure for pediatric patients due to that smaller anatomy as well as the fragility of it. And then it's more complex than the needle crike, which we'll talk about. Some complications, a little bit of bleeding expected during the procedure, can be typically controlled, like we mentioned, with light pressure after the tube's inserted. Now, more severe bleeding can occur if the external jugular vein's lacerated. So make sure that, to reduce that risk, make sure that you're making the incision vertically through the cricothyroid membrane, not horizontally. There's a risk of perforation, so perforate the esophagus, damage to the laryngeal nerves, time sensitivity. It needs to be performed quick to prevent unnecessary hypoxia. False passage creation, so if the tube undermines the subcutaneous tissue and fails to enter the trachea, then a false passage can be created. So typically you might see that with a patient that is, with an obese patient. So what we're talking about is when their anatomy is a little bit harder to navigate. Subacute emphysema or air trapped under the skin after the procedure may indicate tube misplacement, and then aseptic technique as well. We want to make sure that we're doing the best doing the best job of getting things clean and all of that. However, it's not always, these aren't always done in great situations. Now the equipment that you might need, scalpel, so number 10 blades recommended, ET or tracheostomy tube. Use a tube at 6.0 minimum diameter to ensure adequate ventilation. We're talking about adults. Need a tube securing device, tube tamer, suction, sterile gauze and gloves, big bag mask device, and tidal CO2. Those are all going to be kind of requirements that you need. So the procedure, like I said, we're just going to blaze through this, so we'll be doing these in the lab. But needs to be done quickly to minimize hypoxia. We've talked about this multiple times, but you'll identify that cricothyroid membrane. So you'll palpate the V-notch of the thyroid cartilage, so that kind of high and sharp bump, when you can kind of put your neck up like that, you'll feel that high and sharp bump. Locate the cricothyroid membrane, locate the depression. So after identifying that V-notch, slide your index finger down into the depression between the thyroid cartilage and the cricoid cartilage. That's the cricothyroid membrane. Now remember, there is a lot of anatomical differences in males and females. So males typically have a more prominent thyroid notch and thyroid prominence, or what we're saying is that an Adam's apple, and females, the cricoid ring is more prominent. So start by locating the cricoid ring, then the cricothyroid membrane, and finally the thyroid cartilage for reference. Cleanse the area, make the incision, so stabilize the larynx with your non-dominant hand. You're talking about a 1/2 inch to maybe a 3/4 inch, 1 to 2 centimeters, directly over the cricothyroid membrane. So after making that, then remove the scalpel. Use your index finger to locate and maintain the opening in the cricothyroid membrane. If necessary, you can use a tracheal hook or a tracheal dilator to widen the opening for tube placement. Insert the tube. Carefully insert that 6.0 cuff tube or a tracheostomy tube. Direct the tube downward into the trachea, so ensuring that proper placement. Inflate the cuff, typically 5 to 10 mils. And then we just kind of move on with the normal stuff. Connect a bag mask device, auscultate for breath sounds, monitor for belly sounds, confirm placement and tidal CO2, all of that. Post-placement care, that's a good time to start cleaning things up a little bit in the event there is some of that bleeding. Securing your tube, continue ventilating at the appropriate rate. And then, as you see on there, there's the skill drill in your book that talks about it. Now, a needle crike, something that I'm not sure that I've seen done or even heard of anyone do in the field, but it's something you need to be just familiar with. So it's inserted through the cricothyroid membrane, so we're still landmarking the same into the trachea to establish a temporary airway. Now, oxygenation and ventilation are provided by connecting a high-pressure jet ventilator to the catheter hub here to achieve oxygenation and ventilation. Translaryngeal catheter ventilation, so it delivers O2 directly to the lungs using high-pressure bursts. And really, this is just a temporary solution. So, it's designed to maintain oxygenation until a definitive airway. So when we say that, we're talking about a surgical crike or an endotracheal intubation can be secured. Indication is going to be much the same, the same indications. So inability to ventilate, massive maxillofacial trauma, inability to open their mouth, uncontrolled oropharyngeal bleeding. And then advantages: faster, easier to perform. So needle crike is typically faster and simpler than surgical crikes, making it ideal in high stress emergency situations. Lower risk to adjacent structures, reduced chance of damaging those critical structures that we talked about, like a blood vessel. You're just using a very small space versus not that 1/2 to 3/4 of an inch is a large space, but considering that we have a lot of vital structures around there, it is. It allows for further intubation attempts, and then no C-spine manipulation as well. Are some complications. So improper catheter placement can lead to severe bleeding, particularly if you poke a vessel. Air leakage and sub-Q air, so excessive air leakage around the insertion site can lead to some sub-Q air. Also, if too much air infiltrates the subcutaneous space, it can compress the trachea, which causes airway obstruction. And then that ventilation challenges with the jet ventilator. So, if you are using those, make sure you're familiar with them. There's really no reason for us to go over a whole lot of it now, just because it's just me saying a whole bunch of words. And if you're not familiar with it, it won't really make much sense. But you'd use a 12 to 16 gauge catheter, 10 mil syringe, 3 mils of sterile water, saline. These are your things that you're going to need, the equipment you're going to need. Your oxygen source, high pressure oxygen source, high pressure jet ventilator, device, and oxygen tubing. So technique: prepare the syringe and catheter, fill that 10 mil syringe with about 3 mils of sterile water or saline. Position your patient and then identify your landmarks. So we're going to be more of a neutral position. Stabilize your airway structures. Find your cricothyroid membrane. Clean the site. And then insert the needle. So stabilize that cartilage with your non-dominant hand to keep it the anatomy steady. Then you'll insert the needle attached to the syringe to the midline of the cricothyroid membrane at a 45-degree angle towards the feet. So advance the needle once you feel a pop, so kind of indicating entry into the trachea. Advance the needle an additional 1/2 inch or about 1 centimeter to ensure proper placement. And aspirate to confirm placement. Evaluate for incorrect placement. And advance the catheter over the needle until the catheter hub is flush with the skin. Withdraw the needle, place it in a puncture-proof biohazard container, obviously. And then you'll attach your jet ventilator on there. So carefully advance the catheter over the needle until the hub is flush with the skin. Once the catheter is fully advanced, then you'll withdraw the needle completely. We mentioned make sure you dump it into your sharps, connect your tubing. And there we are. You thought we'd never get there, but we did. That is the end. It's been nice chatting with you guys for a little bit, and we'll see you next time.